Hello, and welcome to the 7th lecture in our series of endocrine presentations. Today we'll talk about thyroid hormone disorders, both hyperthyroidism and hypothyroidism. Hyperthyroidism occurs when there's too much thyroid hormone, and hypothyroidism occurs when there's not enough thyroid hormone. And you might consider thyroid hormone as setting the idle speed of your cellular processes. How fast or how slow do these processes run? First, a brief review. The hypothalamus monitors the body's need for thyroid hormone, and if it's needed, it sends a signal, TRH, to the pituitary. The pituitary then releases thyroid-stimulating hormone, which triggers the formation and release of thyroid hormone from the thyroid gland. The thyroid hormone then feeds back to decrease the secretion of TSH and TRH. The negative feedback loop here is essential to understanding the laboratory evaluation of thyroid disorders, so if you're struggling with it, please see Lecture 6 in this series. So let's start with hyperthyroidism. Hyperthyroidism is a hypermetabolic state. Everything's running too fast, and that's because there's a high level of thyroid hormone. So you can consider everything's running too fast, there's too much, and the symptoms then would include weight loss, rapid heartbeat, palpitations or irregular heartbeat, and atrial fibrillation, especially in the elderly, nervousness, anxiety, insomnia, a fine tremor, heat sensitivity, which means that the patient is feeling warm when everyone else is comfortable, more frequent bowel movements, and for women, menstrual irregularities. There are many causes of hyperthyroidism. We're going to look at 3 of the most common and 1 rare disorder. And these include Graves' disease, multinodular goiter, thyroid adenoma, and pituitary disorders. So the way this works is that TSH binds to thyroid cells, and the receptors, when they're occupied, trigger the formation and release of thyroid hormone, T3 and T4. Now, most of the hormone produced is T4, about 80%, and about 20% is T3. T3 is more biologically active, and in many tissues, T4 is converted to T3. One more fact we need to know about thyroid hormone, and that is that thyroid hormone is bound to proteins in the plasma. The vast majority of both T3 and T4 sticks to protein. Now, if it's stuck to protein, it's not biologically active. So when you want to measure thyroid hormone, you really need to measure the free hormone. This is especially true because a number of conditions can increase or decrease the amount of protein. And what you're really interested in is the free T3 or T4. And for most purposes, a free T4 is the lab that's used to assess thyroid hormone quantity. So let's talk about Graves' disease. Now, normally, thyroid-stimulating hormone binds to the receptor and triggers the formation and release of thyroid hormone. Graves' disease is an autoimmune disorder in which the body makes antibodies that bind to and stimulate TSH receptors. And this stimulates the formation of T3 and T4 independent of the TSH levels. Along with this hyperthyroid state, this excess production of thyroid hormone, Graves' disease is marked by a diffuse swelling of the thyroid gland or goiter, and in some cases with in some cases the antibodies attack the extraocular muscles and the fat pad behind the eye, causing the orbit to swell and pushing the eye forward. That's called exophthalmos. So the laboratory investigation then of Graves' disease, as you might expect, the free T4 level would be high, and as a result, negative feedback would reduce the TSH level. Now you can actually test for these antibodies to TSH receptors, and if you do that test in Graves' disease, it will be positive. Another assessment of thyroid function and anatomy is to give the patient radioactive iodine and then look for where the radioactive iodine shows up in the gland. For Graves' disease, the radioactive iodine uptake would be high and the uptake would be diffuse across the entire gland. Now, the treatment for hyperthyroidism due to Graves' disease is to simply reduce the T3 and T4 levels. This is very important because untreated Graves' disease can have up to a 30% mortality. The patient enters what's called a thyroid storm, and the hypermetabolic state is so extreme that the patient's temperature rises out of control and they may wind up with cardiac failure. So the modalities for treatment include medication, radiation, and surgery. For medications, PTU is not used very commonly because it does cause, in some patients, liver damage. It is, however, okay to use in the first trimester of pregnancy, and that's where you mostly will see it used in clinical practice. Methimazole is the mainstay of treatment, and both of these drugs block the uptake of iodine. PTU, in fact, blocks the conversion of the less active T4 to the more active T3 thyroid hormone in the tissue space. One very dangerous side effect of methimazole is agranulocytosis, a reduction in white blood cell count. The patient needs to be given written instructions with this drug and told that if they develop a fever or a sore throat that they need to report immediately. Another mainstay of treatment for Graves' disease is to give the patient radioactive iodine. Now, since the thyroid gland concentrates iodine in the body, almost all the radiation is going to be concentrated in the thyroid gland. And the goal here is to actually destroy the gland. You don't want to try and save just enough of it to make the patient euthyroid. There are many calculations that can be done to try and adjust the dose. They usually don't work very well. So the goal is to simply destroy the gland and then to replace the thyroid hormone. Another method of treatment is surgery. You simply remove the thyroid gland. The complication here is that the recurrent laryngeal nerve, that's the nerve that allows the larynx to open, runs very close to the thyroid and is very easily damaged. If this nerve is damaged, it can cause unilateral, or if both nerves are damaged, bilateral paralysis of the vocal cords. Another surgical issue is to be sure to leave the parathyroid glands when you take the thyroid gland. Otherwise, the patient will have a problem with calcium ion homeostasis. Another cause of hyperthyroidism is actually something that eventually becomes hypothyroidism, and that is inflammatory diseases of the thyroid gland. So initially, the inflammation can release excessive thyroid hormone, and then as the gland is destroyed, the thyroid hormone levels drop below normal. And we'll talk more about this in a bit. Multinodular goiter is another cause of hyperthyroidism and is, as you might expect, an enlarged thyroid with multiple nodules. One issue with this disorder is that you must rule out thyroid cancer. Ultrasonography and fine needle biopsy may be in order. The laboratory evaluation for multinodular goiter would show a high free T4 and, because of negative feedback, a low TSH. The thyroid stimulating immunoglobulin would be negative, and the radioactive iodine would show both hot and cold spots corresponding to hyperactive and inactive thyroid nodules. The treatment for multinodular goiter is either ablation, destruction of the thyroid gland with radioactive iodine, or surgery. You may have one solitary thyroid nodule, a thyroid adenoma, and this nodule has escaped control of TSH. It's going to be making a lot of thyroid hormone regardless of the TSH level. So of course in this case you'd expect to see a high free T4, and again because of negative feedback, a low TSH. The thyroid stimulating immunoglobulin would be negative because we're not dealing with Graves' disease here. And the radioactive iodine uptake would be high in the nodule and low in the rest of the thyroid. Again, the treatment for thyroid adenoma is either radioablation with iodine or surgery. And in this case, because the nodule is hyperactive, it's going to concentrate the radioactive iodine, and you may spare the rest of the thyroid. Thyroid cancer can also be a cause of hyperthyroidism. Now, an unusual disorder that can cause hyperthyroidism is a disorder in the hypothalamus and pituitary itself, for example, a TSH-producing tumor in the pituitary. Now, in this case, the labs are going to be a bit different. Pause the video and see if you can figure out what the free T4 and the TSH would be in this case. Well, it's hyperthyroidism, so you'd expect the free T4 to be high. And in this case, the TSH would also be high because that's the cause of the hyperthyroidism. The disorder's not in the thyroid, it's in the pituitary. The TSI would be negative and the radioiodine uptake would be high because the gland is hyperactive. One other cause of hyperthyroidism is the cardiac drug amiodarone. There are other causes of hyperthyroidism, and if you'd like to investigate further, please see the show notes for some references. Now let's move on and talk about hypothyroidism. Well, that would be the opposite of hyperthyroidism. So hyperthyroidism was too much too fast, and hypothyroidism is not enough too slow. So in this case, the symptoms would be weight gain, slow heartbeat, depression, impaired memory, sensitivity to cold. Your patient's cold, everybody else is comfortable. Constipation, fatigue, and menstrual irregularities, heavy and irregular periods. There's also a skin condition, a kind of a skin edema called myxedema demonstrated here, and it's often referred to as pretibial myxedema because it's found in this area. In this slide, we see a picture of a patient before and after treatment. Hashimoto's thyroiditis is an autoimmune disorder in which the antibodies attack and destroy the thyroid. These antibodies are not the same as the antibodies that cause Graves' disease and can be tested for. Initially, it may present as hyperthyroidism because as the gland is attacked and destroyed, large amounts of T3 and T4 are released into the circulation, but eventually the free T4 will drop, and in laboratory investigation, you'll see a low free T4 and a high TSH level. The thyroid stimulating immunoglobulin will be negative, and the radioactive iodine uptake will be low. Another cause of hypothyroidism is post-treatment. If you destroy someone's thyroid gland with iodine or you remove it surgically, they're going to be hypothyroid. And the treatment here is simply thyroid replacement. Interesting to note that the physicians in the Tang dynasty were treating patients successfully with goiter by using iodine-rich glands from sheep and pigs, or in a pill or powdered form. Today, we use thyroxine, thyroid hormone replacement is inexpensive, convenient, readily available, and without complications. It's also identical to the thyroid hormone made in the body. And that's all we have to say about the disorders of the thyroid gland. Thank you for your attention.